trauma case scenario, understand the principles of damage control. So what's advanced trauma life support? What's called ETLS. This is an American course which has been applied in many countries. And I think it is essential in many countries to have this course before getting a job, before progressing in your career, not only as an orthopedic surgeon, but as a physician in general. It deals with the initial management of trauma and how you manage a polytraumatized patient and how you manage, polytrauma, more than one patient involved in an accident, and how you manage a polytraumatized patient or a patient with multiple injuries. There are two other categories which is out of the scope of this lecture today. We can do them later on, and this is about mass casualties and the disaster management. This is not included in this talk. Mass casualties, if you have, for example, a disaster in a stadium or maybe an earthquake or something like this. Disaster management is maybe like a tsunami or something massive, and that is a different story. So back again to this picture, which is, as you can see here, striking and scary, very scary. If you can imagine, you are as a physician, not just a surgeon, just, even if you are a newly graduate doctor and you are the only doctor in your family and you are on the road and then you found this car. You are very lucky that you are not inside this car, but you watch this car and you have 5 patients inside this car, okay? And then your family looking at you, you are the doctor, you are going to save lives. Okay, so if you are an orthopedic surgeon and you are trained and you know how to do nails and plates, but you cannot help patients in an accident like this, then that is not good. So what I'm going to make for you, I'm going to make this story a bit easier, okay? So rather than asking you how you manage these patients at the scene of the accident, how are you going to extract these patients from the car? How are you going to save their lives? How are you going to assess them and resuscitate and save lives? That's very, very difficult. So let us make it much easier and say, okay, you have 5 patients from this car. You found them in the casualty department, and you are on call as an orthopedic trainee resident, or even as an orthopedic consultant. You are a consultant, but your trainee or your registrar asked you for help. Please come, we have 5 patients coming here in casualty and we need your help. So here, what we call triage is how to sort. Triage is a French word, means sorting out. It was used to sort out the rule, and this word now used commonly in casualty. So there is a triage nurse in every casualty department, so that they will sort out the patient according to the priorities for treatment. Some of these patients could die in 5 minutes or in few minutes if you don't look at them. So you are the only doctor now coming to casualty, and you have these 5 patients. So I am going to ask you, and then you can use the chat or the question and answer and write your answer. Now, please, which patient you're going to treat first? Is it number 1, number 2, number 3, number 4, number 5? I'm going to give you half a minute to read it and tell me which one you should treat first. Just put the figure, 1, 2, 3, or 4, or 5. Which one you're going to look at first to save lives, because he could die in 5 minutes.
We got 3 most answers, 5 and 2 answers.
So we have 5, we have 2, we have 3.
3 the most common
of them,
one,
yes.
answers.
And we have 5 and we have 2, correct?
Yeah.
We don't have 1 and 4?
Only 1, 4.
Yes, there's 1, okay. There's 1 for 4, okay.
Yeah.
So anyone who is not going to look at number 1 means that he is not scared from this patient who's crying and who's shouting and saying, okay, I am so and so, I'm a very important man, you don't know me, you're leaving me, I'm going to sue the hospital, I'm going to, to take you to court or whatever. So you are not listening to this patient, okay, you could be in trouble. Let us see, okay? And let us see also if this patient could die later on, Okay, we will see. And if you don't choose number 4, few of you choose number 4, then you really don't have heart. You have a patient who has got a fractured skull, open fracture, and a bleeding coming from the head, and the brain is popping out. Okay, you can see parts of the brain even with this open skull fracture, and he's still not looking at this patient. Okay, so you said that the majority are number 3. I'm very pleased to hear this. Okay, because this is the right answer. Yes, you should choose patient number 3. And the reason for this, this is my second question. I can see from your answer that you have different answers. Some of you choose 2, some 3, some 5, some 4. Okay. This means that every one of you has a different way of thinking, have a different way to manage these patients. Does this mean that every one of you had different training? Or is it democracy that everyone will say whatever he likes? No, there is no democracy here, sorry. I mean, this is about saving lives. You must have a system. You must have a common language. We all should speak the same language. So there is no time here for thinking or making ideas. You must have something clear in your mind and you go for it. So the reason there are differences in the answers, it could mean that you have different principles in treating this patient, or maybe you have the same principle, but you don't know how to apply it. So can you write also in the question and answer, what is a principle that you based your decision on?
ABC, treat airway first.
Okay, it's good to hear ABC, but if all of you know the ABC, but when you come to applying the ABC, you don't know how to apply it, this means that there is a discrepancy between what you know and what you apply. And as you know that the level of knowledge is different. It starts first by recalling, يعني يحفظ some يعني, and after that is understanding, and then after that is application, okay, and then you go to the higher levels, okay, with analysis and senses and all that. But at least let us stick to the first 3. You need to know the knowledge or recall it, and then you need to understand what ABC means, and then you need to apply it. So when you apply it, means that all of you should have one answer, because all of you have a good understanding of what ABC means, which is airway, breathing, and circulation. Means that you should treat the patient with airway problems first, and then go for breathing problems, and then go for circulation problems. Okay, so if we understand this, then we apply it as it is. So for airway, number 3 is the one who has got a blocked airway. Airways means the corridor where the air goes, either from the mouth or from the nose down up to the lungs. Okay, in this corridor, it could be blocked anywhere. Okay, and this is very critical, because if you don't have air, then the lungs will not be working. So if you have the airway blocked, then there will be no breathing. So that's why A is first, airway, and then breathing. Okay, and for airway, patient could die in few minutes. So when you have a patient who's quiet, he's not talking, okay, and his mouth is filled with blood, means يعني ده واحد زي غرقان. الغرقان ده بيبقى الميه هي قافله برضه نفس الكلام هنا. Blood will block the airway, and in this case he's not going to be able to breathe, and that's why he's quiet. Okay, but that patient was crying. If he's crying, it means that the ABC is good. It means that the airway is good, the breathing is good, and even the circulation. He did not reach a stage of shock where he could, lose his conscious or will not be able to. Although the first degree of shock could make the patient in distress, but if the patient is talking, generally speaking, we consider that this is a good sign that the ABC is good. So here, patient number 3 has got blocked airway, and you should pay attention first to this patient before you go to patient number 2, which is the labored breathing, okay? Because this one is a difficult breathing. He is using the accessory muscles. It means that there is something, could be pneumothorax, hemothorax, whatever, okay? And then after that, the circulation, and just for the sake of time, I will not be able to make this interactive for all questions. So number 3 is the third patient will be the bleeding brachial artery, because this is a major artery. The bleeding from the skull will stop because this is not major vessels here, right? And then after EBC, there is something called D and E. D means disability. So after sorting out airway, breathing, and circulation, then you look at the disability like brain injuries, spinal cord injuries, okay? And then the last one is what's called exposure, which is E. So it is A, B, C, D, E. E, which is exposure, means that you have to examine the patient from head to toe in order to discover other fractures, abdominal injuries. It could be a ruptured spleen, it could be a fractured pelvis. So this patient who's crying, definitely the ABC looks good at the start, but he could deteriorate later on. But he may take few hours, probably. You know, for example, if he has got a fractured pelvis and he's initially fine, and then he's going to go into a first-degree shock, second-degree shock, and then gradually, if you don't pay attention to him and examine him and resuscitate him, he could die. But that's going to be at a later stage. So here is the ABC, as we said, ABCDE, airway, breathing, circulation, disability, and exposure. The lack of diagnosis should not delay the treatment. Here is not like the traditional medicine, where you have, for example, a patient with diabetes or for osteoporosis, for example, and then you're taking a history and trying to find out what are the causes and what is the diagnosis and differential diagnosis. No, there's no time for this. If you have a patient with shock, if you have a patient with blocked airway or whatever, you need to resuscitate first. You need to give the patient oxygen. You need to give the patient fluids. You need to put catheter. You need to resuscitate this patient and then find out the detailed history later on. So we must have a systematic approach. As I said, it is not good to have different opinions like what we got from your answers in the first slide about triage, okay? And time is the essence. So every minute wasted here can, as I said, kill a patient, okay? So for ETLS and the ABC, there is something called primary survey and second survey. Primary survey is actually the EBC. So during this time, you're making an assessment for the EBC and you resuscitate. So as I mentioned, you give oxygen, you give fluids and all that. If there is bleeding, you look for blood and so on. During this time, in addition to examination, you have to do x-rays, and x-ray is the chest and pelvis. Chest, because for breathing problems, you may have pneumothorax or hemothorax or major vessels, okay, injury or widened mediastinum, and pelvis also fractured pelvis, and then also the cervical spine. After stabilizing the patient, then you're going to look at the secondary survey. The trauma worldwide is the first cause of death for age 0 to 45, and it is the third cause of death for all ages after cardiovascular tumors. In Egypt, the story is different, unfortunately, because in Egypt, the first cause of death for all ages is trauma. So we have a high incidence of trauma patients here on robotic accidents. Victims, unfortunately, are the young, most productive. They're responsible for their families and their economy, and their either death or disability is a major loss. And it is very disturbing to know that the death from road traffic accidents and polytrauma is much more than what happens in wars, and also disabilities is about 3 times than the death. The impact of the ETLS training, if you could improve the results and made a difference, especially casualty, you don't need a specialized doctors here in casualty. You just need people who are trained on how to manage, or to do the initial management for trauma, so that they can prevent at least 25% of this and disabilities at this initial stage. Here is the X-ray of the chest and pelvis. We are orthopedic surgeons. We know how to read the pelvis X-ray, but we don't know well how to read chest X-ray. But I think it is good to know how to spot pneumothorax, hemothorax, widened mediastinum, or any damage to the heart. Here is a scenario for a patient, which I'm going to discuss very quickly. This is a patient who came with an open fracture left tibia. Okay. And as you can see here, this is a cervical spine X-ray. You can look at it. I will give you half a minute. And you can tell me if there is anything wrong. You can either say normal or abnormal. And you can say what's wrong. Okay, here's the open fracture tibia, and the orthopedic specialist seen the patient and say, all right, this patient is an open fracture. We're going to put an external fixator for this patient, and he's preparing the patient for theater. Okay, here is the details. This patient is 42. It is RTA, and it is a motorbike. Okay, open fracture tibia. Patient does not have pain in his neck, and he has got hypotension and bradycardia, and not responding well to fluids. There is paradoxical chest movement, and he is moving his arms, but with a bit difficulty. And he's complaining of severe pain in his left leg. Based on this information, do you have any diagnosis for this patient? Any suspicion about anything? Any worries? Motorbike accident, probably was thrown away, maybe several meters away from his motorbike. You get that open fracture tibia, and patient is talking, but when you talk to him, do you have any pain in your neck? No, and he has this hypertension, bradycardia.
Chest trauma, cardiac arrhythmia, shock.
Shock, yes, hypotension means shock. But with shock, with hypotension, usually there is tachycardia. Here, the patient has got bradycardia, which is unusual. Pneumothorax. He got paradoxical chest movement, which is different from the flared chest. That the paradoxical chest movement means that the chest and abdomen are not moving in the same direction, paradoxically moving, which is called diaphragmatic breathing. That the diaphragm is the only muscles which is working. Means that all the intercostal muscles are not working. The patient was sorry.
Neurologic shock, 3 attendees.
Absolutely, yes, well done. Neurogenic shock, because this is the only type of shock where you have bradycardia. All other types of shock, they have tachycardia. So now we have this patient has got neurogenic shock. This will tell us something. The other thing is also, he has got diaphragmatic breathing. It means that the only respiratory muscle that is working is the diaphragm, which comes from 2, 3, and 4, cervical 2, 3, and 4. But all the chest intercostal muscles are not working, means that they are paralyzed. Paralyzed means that there is a cervical spine injury above that level. But this patient is moving his arm, but with difficulty. He is moving his arm, but he has got a trick motion like this, okay? So he has got, he is using the gravity to do the extension for his arm, and then he's using the biceps. So the triceps is not working well, but he's using the gravity with a trick motion, but he's using the biceps. And this can tell you something. The biceps is C5 and 6, the triceps 5, 6, and 7. Okay? So this means that the triceps is not working well, but the biceps is working. Okay? And then he got severe pain in his leg. So how he could have neurological problem with severe pain on his leg? It could be a partial, not complete spinal cord injury. Okay, so in this case, he might have pain, but the power, he lost some of the power and some of the sensation, but he has got some preserved sensation. This could happen with incomplete spinal cord injury. Here is the X-ray. Is there anything wrong in this one? Okay. So this is a message to you, is never accept the cervical spine X-ray without seeing C7. Never ever. Okay? You have to see the junction between C7 and T1. I know this is very difficult, especially in obese patient with short neck. You need to do either a swimmer's view. Nowadays, it's very easy to do CT scans, but still, you can do it in casualty. There are many ways to do it. Either you can pull the patient arms and relax the patient, or you can do a swimmer's view like this with the patient moving his arm up like as if he's swimming. And then you can take a shot and you can see the junction between 6, 7, and T1 and the other upper cervical. You can see them in the normal lateral X-ray. Okay, so here this can explain to you that this patient has got this cervical spine dislocation or subluxation, and he has got incomplete spinal cord injury, and you can see the level here: 1, 2, 3, 4, 5, between 5 and 6. So this is the level of the damage, and that's why he was moving his arm. As I said, the biceps is working, but not the triceps. Okay, keep yourself aware of these lines here. And when we were talking about EBC, I forget to mention that the A is the airway, but it comes with it cervical spine control. So it means when you are looking at the airway with any polytrauma patient, you need to keep the cervical spine in line, and it needs to be immobilized, because there could be a patient like this who has got incomplete spinal cord injury, and if you move this patient, or if you the patient moved his neck, then he could convert himself into a complete spinal cord injury with complete paraplegia, with good chance of recovery. But the incomplete spinal cord injury in the studies, as we know, it depends on Frankel classification 1, 2, 3, or 4, and it could be more than 90% chance of recovery. Depends on the Frankel classification level. Okay, but I can see here the lines. I think you are an orthopedic surgeon, you know these lines. You need also to look at the soft tissue, and you have two soft tissue here, one at the top here in front of C1 and C2, and the other one, so the pretracheal and prepharyngeal, and you need to look at the figures here and how many millimeters they are. So in any patients who has good cervical spine injury, this soft tissue damage will be high. This is explanation to all the questions that I put. So every point I give to you, it gives you a hint. Motorbike means the mechanism of injury can cause cervical spine. So you must have a high index of suspicion when somebody tell you that, okay, I felt, you know, I was diving from a very high level and I fell and my head came first or whatever, and hit the floor. So from the mechanism of injury, if somebody was parachuting, paragliding, motorbike, all these cervical spine injury. The open fracture tibia is a distracting injury. That's why this patient did not feel pain in his neck. He was shouting from the pain in his tibia. The hypotension and a bradycardia gives you a hint. This is a neurogenic shock. So when you get neurogenic shock, you get it when you have a spinal injury, or there are other reasons for neurogenic shock. But for this particular patient, you need to think about neurogenic, think about spinal shock. Also, you need to differentiate between what's spinal shock and what's neurogenic shock. Neurogenic shock is a circulatory shock. The name could be confusing because it's called neurogenic, but in fact, it is describing a circulatory shock. There's a problem with the circulation. There is hypotension, okay? But spinal shock has nothing to do with the circulation. It is a concussion of the spinal cord, like the concussion you get in your brain. So when you have a spinal shock, part of the spinal shock, because the sympathetic is paralyzed, then you get that neurogenic shock. There is a parasympathetic overflow. There is a repetition of the vessels in the periphery, and that's why you get all the blood, most of the blood pooled in the periphery, and you get the neurogenic shock. The paradoxical chest movement, diaphragmatic bleeding, means the diaphragm is working because the level of this injury was C5, C6, means that the diaphragm, which is C2, 3, and 4, was working, but all intercostal muscles are not. Moving his arm, as I mentioned, this is a trick motion to compensate for the triceps. the severe pain because of incomplete spinal cord injury. And I think I need to stop at this slide, and I'm happy to take any questions.
We are ready for any questions for Professor Mahmoud Hafez.
دكتور محمد بيه، ازي حضرتك؟
دكتور ادهم باشا، ازي سيادتك؟ اهلا بيك يا فندم، منور.
معلش انا ليا يعني هو مش سؤال. دكتور محمود بيه، ازي حضرتك؟ حضرتك وحشني.
ازيك يا ادهم باشا، اخبارك ايه؟
ازيك دكتور احمد؟ تمام؟
ازيك يا باشا، ازي حضرتك؟ اهلا وسهلا دكتور ادهم بيه.
طبعا يعني نشكر الدكتور محمود بيه على المحاضره الجميله دي.
انا لسه ليا شكر للدكتور محمود for this very interesting and very unique style of presentation.
مختلف فعلا.
Yes of course.
هو انا يعني تعليق بسيط، هو فعلا دكتور محمود زي حضرتك قلت المانداتوري اكس رايز during the primary survey has been for decades، اللي هو الشيست اي بي والبلفس اي بي واللاترال سيرفايكال سباين. بس هو دلوقتي في الاي تي ال اس هم have been replaced اللي هو اللاترال سيرفايكال سباين بالفاست اللي هو الفوكس اللي هو الالترا ساوند اوف ذا ابدومين. فبقى المانداتوري راديولوجي اللي هو الاي بي تشيست، اي بي بلفس، والابدومينال الترا ساوند. تعليق بسيط يعني.
لا that's a very good point. I'm ATLS instructor, and that's a very good point, and that's why I did not put the cervical spine X-ray in here. I did not put the fast, but most of the people are familiar with chest X-ray and cervical spine. The fast, it all depends in the hospitals here in Egypt and whether they're familiar with it, and people who are you know, as you know, it is operator dependent, and it depends on how people are familiar with. But it's a very good point, and thanks for this.
شكرا.
Any other questions?
We have a question from Dr. Harith Al-Haj Muhammad. I think there is a new ATLS system that came before E and that C came before A and B. What's your comment, sir?
Yeah, I think there's talks about this, but I think it's the ABC, and that's what we're all familiar with. And probably Dr. Adham could, if you have any comment on this, I think the ABC is still the standard.
Any other questions? From Dr.
Question here: should I immobilize the neck in any significant trauma, or there is specific indication? So he's talking about the neck collar immobilization.
Yes. I think the neck collar, the most difficult part for any orthopedic resident or registrar in casualty, you know, in UK or US or anywhere, is how to remove the collar, because every patient comes with the ambulance with the collar on, and the orthopedic staff are responsible for taking the collar off. Okay, and that's different from what we see sometimes in Egypt here, where patients come and we have to put the collar on them. Okay, so taking the collar off or putting the collar on, I think this is very critical for orthopedic surgeon, because it's your responsibility. You are the specialist. Okay, they're not going to call the neurosurgeon to do this, right? As a rule of thumb, any patient who is coming with polytrauma, and also depends on the mechanism of injury. We are not talking about a patient who was hit by a stick on the ulna or on the tibia or something like this. We're talking about polytrauma. In this case, you have to immobilize the patient. You have to put the collar, and the rigid collar is a Philadelphia collar, and still it does not prevent complete motion. It's about 40 to 60%. So in this case, you have to really put two, either the stretcher has got the spinal immobilization system, or you have to put like 2 blocks if you are on the road, and put any band, a sharp or a haga, and tie the patient until you clear the cervical spine. You clear it from symptoms, patient having pain in the neck or having any symptoms. At the examination of the neck, you see if there is a tenderness, if there is a step, and hemosis or whatever. And then also you need to find out from the X-ray, the lateral X-ray, and then nowadays the CT scan definitely is much easier and can give you a good diagnosis.
Yes, we have a question, Professor Mahmoud, from Dr. Yasser Shalabi. He's saying that he missed the first part of the presentation and he don't know if you mentioned the Canadian scoring system.
No, I didn't mention anything about the Canadian scoring system. No.
Dr. Adil Kurfa is saying that I think C is for circulation and cervical spine.
Yes, for circulation and cervical spine. Probably I'm talking about the case scenario. Is he talking about the diagnosis of the case scenario or?
The case scenario? No, I think he's asking about the abbreviation C. What means by C?
C is the circulation.
Circulation.
Okay.
He's saying that it's for circulation and cervical spine. No,
well,
I think
cervical spine comes with A because it is related to the airway. Okay, because you know if the cervical spine, with some cervical spine injuries, you can compromise the airway, and it's very important because if you have a brain stem injury, you have a breathing center in the brain stem. Okay, and I mean we all know about the hangman's fractures. Okay, so if you have a patient with hangman's fracture, you could die. Okay, die from breathing, not die from anything else.
Yeah, from Muhammad Halak, he's saying that C, A, B, C, D, E equals acute bleeding first, then airway. Is that right?
This is similar to the previous question about the circulation before the airway, but I mean, as far as I know, that's the ABC that we follow.
Yeah,
I think he added another comment. He said that in Germany, C small, then A, B, C, D. This refers for cervical spine and acute visual bleeding. So I think there might be something different.
If you say cervical spine with the A or before the A, so it is the same, because A is it's called airway and cervical spine control together.
Yes, another
I mean, as you know, that there are different resuscitation systems. There is a European resuscitation system, and as I mentioned in the first slide, that the disaster management and the mass casualties management, they also have different protocols. So, for example, let me just give you an example. If you are in war, okay, or if you are in a tsunami, in this case, you don't treat the same way as EBC. There, the walking patients are the one you're going to save. So if somebody is walking and has got a fracture, or somebody is breathing and he has got some difficulties with something, that you can carry on and manage, and you could be leaving somebody with airway and breathing, okay? Because here you have mass casualty, you have hundreds, thousands of patients, and you will not be able to save lives for all. So in this case, you cannot spend all the time on managing a patient with airway and all others could be dying. So that it's a different scenario, and the same happens in wars.
Yes, sir. Another question, sir, from Dr. Muhammad Ali. In hypovolemic shock in children, what's the rate of crystalloid and colloid infusion?
Oh, no, I wouldn't be able to answer this question to you. You need to look at the formulas, and it wouldn't be at the top of my mind to say it now.
Yeah.
But what you need to understand is, for children, they have a small size. Yeah. Okay, so they could lose the volume easily. So that they are very sensitive. The extremes of age, either the elderly or the young. The elderly, their physiological mechanism is not normal. Okay, and you could overload them easily. The very young, they could lose fluids very easily, quickly. Okay, so you need and in burn. I mean, we know the rule of 9 in burns, for example. Okay, so the rule of 9 in burns is different in adults from children because the size of the children, you know, like the head is big, okay, as compared to the other parts. So that's why the formula is different in the children, but overall the same principles applies, which is resuscitation. You have a patient who is hypovolemic, you need to give them fluid, so resuscitate and assess. Okay, and if you found that the patient is responding, that's good. If the patient is losing blood, you need to get blood. Blood may take time and you need to warm it. So by this time, you need to give something else in waiting for the blood to come.
Dr. Ahmed Sheikh, any other questions for Professor Mahmoud Hafez?
I don't think so. There's just one question from our dear colleague, Dr. Yasser Shalabi. He's saying that ATLS approach has changed in the last 2 years. It used to be ABC, now it's CABC. The first C is for major hemorrhage. I know the sensor bust is ATLS, so he's asking about
Professor
these.
Mahmoud had just mentioned.
Yeah, I'm aware about this. I mean, with regards to the major hemorrhage, you know, like if you have a patient with major vessels, okay, most of these patients don't come to you if they survive, and definitely if they come to you and you realize this, that's definitely you have to pay attention to them. I totally agree with that. Yes.
Professor Mahmoud, thank you so much for this very interesting and very unique style of presentation. It was a very fruitful presentation for all of us. Thank you so much, sir, and hoping to see you in many other